welcome back, everybody. We're going to talk here about a number of disorders that affect the gallbladder, as well as a couple other things that affect the biliary tract. But what we're going to see here, one of the things that draw these all together is that the problem ultimately stems from the gallbladder. So that's why I included these things in the acute gallbladder. Now, one of the things we're not going to talk about is gallbladder cancer, because that is not so much acute. And so I wanted to keep this limited to some of the higher yield things that come up as right upper quadrant pain that stem from the gallbladder. Now, I know that sounds like I'm narrowing it down, but I'm not really, because all of these things are very, very high yield. And so, as you know, there are a number of questions on your exam, 318 on step 2, 412 on step 3 divided over 2 days. So you can bet you're going to get a number of questions on the right upper quadrant, on the biliary tract. You need to know how to work this up. Right upper quadrant pain as a presenting sign is almost guaranteed to come up on your CS, or CCS rather. I suppose it used to come up on CS, but you don't have to take that test anymore. So this is all going to be very high yield stuff for you to know. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I heartily thank all those of you who have already donated. And definitely subscribe to my channel and you'll get notifications every time I put a new video up. All right, so we'll briefly look over the anatomy. I'm going to give you some general principles, some rules that will help you in general as you approach these questions. We're going to go over 6 things. Again, all of these are very high yield. I would say biliary dyskinesia is probably the lowest yield, but still high yield. So all of this stuff, very important. We'll run through some of the complications, and then I'm going to give you a nice, helpful algorithm that I think will be useful for you as you approach test questions. All right, so here is our anatomy. So keep in mind that the gallbladder is right here. It sits inferior, posterior to the liver, but mostly inferior. Very short ducts here. These are not very long ducts, and they're also very narrow. So it's very easy for a stone to get lodged in these ducts. Bear in mind, here is the neck and the cystic duct coming right out of the gallbladder. That is the most common place for you to get stones, which leads to acute cholecystitis. I should say the most common place for stones to lodge. And note its proximity to the common hepatic duct, which is right next to it, and that's going to be important as we go forward. All right, so this is what we're going to talk about. So here's some general principles. Most patients who have gallbladder pathology will present with right upper quadrant pain. When a patient has right upper quadrant pain, your best initial step is a right upper quadrant ultrasound. Now, yes, we're getting all these other labs and we're going to get them right away. We're talking CBC, looking for an elevated white count, which can point to an infection. CMP, which remember is your electrolytes and liver function. That can look for hepatocellular versus biliary tract dysfunction. Amylase, because some of this can masquerade as pancreatic etiologies. Urinalysis, because right upper quadrant can actually be right flank pain, which can be difficult to distinguish. So look for a UTI. And then, of course, anytime we're dealing with abdominal pain in a woman of childbearing age, we need to exclude pregnancy. It's very cheap, and you're covering your you-know-what. And then depending on the patient, you may do other things. If you're dealing with an older person with kind of upper abdominal pain, possible cardiac etiology, so get EKG and enzymes and chest x-ray and so forth. Remember, when you're taking CCS, that yes, you're doing your diagnostic workup, but we have to make sure that we're treating the patient's pain, that we're stabilizing them. So antiemetics, IV fluids, and pain relief are going to be important. MRCP is a tempting test to go towards, but we generally don't do that. Right upper quadrant ultrasound is our imaging of choice. MRCP is usually done when ultrasound, CT are equivocal or negative, and yet we still have a high index of suspicion that we're dealing with a biliary etiology. And please remember that the painless, palpable gallbladder with jaundice is cancer until proven otherwise. That's the Courvoisier gallbladder. Very, very, very important. You know that that does get tested. All right, so I included some vignettes here. You can read them and look at what I highlighted, and you can see kind of how these show up. But I'm not going to read through all of these because it's just going to take a lot of time, and you can do this on your own. Okay, so let's talk about biliary colic. Biliary colic is pain that is not due to a stone or an infection. So basically what we have here is a transient blockage, typically at the cystic duct, and when the gallbladder contracts against that transient blockage, just like with any blockage, you're going to get pain. Okay, so this is fairly common. Now, it is transient, so eventually this goes away, but what do you think is causing that blockage? Little gallstones. And so these patients who have biliary colic are at significantly increased risk for eventually developing acute cholecystitis if they get a stone that goes into the duct that's big enough and is not transient. So the symptoms here are pretty much all the same as acute cholecystitis, which we'll run through, but I hope you know because it's a very, very common disorder. But what we're going to have here is all the same symptoms with the colicky abdominal pain, right upper quadrant, gets worse with fatty meals. But you're not going to have fever. You're not going to have elevated white count because this is not an infection. This is just pain. Now, these episodes come and go. They usually last less than an hour, and then but they go away within hours. So this is not a constant pain. This is not what you experience with acute cholecystitis where it just does not go away. The diagnosis here is a right upper quadrant ultrasound. It's actually superior to CT, which is unusual. Usually CT is a better imaging test. However, one of the problems is that ultrasound is operator dependent. So if you have a really experienced sonographer, then ultrasound is better. If you've got a medical student doing the ultrasound, then CT might be more accurate because they may miss things. Stones should be visible, but the gallbladder itself will appear normal. You won't have any pericholecystic fluid. You won't have any gallbladder wall thickening. You just see the stones in the cystic duct or in the wall or the neck of the gallbladder. The treatment here is nothing. It's just pain relief and inform the patient that they should consider getting a cholecystectomy as definitive treatment. Here's your normal gallbladder here. So you can see a fairly thin wall. That's normal. And then you have a nice view here of the neck and the beginning of the cystic duct. Now, when you have biliary colic, you should see more or less a normal gallbladder, but you will see some stones in the gallbladder. So here are the stones right here. Okay, so here's another vignette. So biliary dyskinesia, what is this? This is disordered motility of the biliary tract. So basically what you're going to have here is a picture very similar to biliary colic, but the difference here is that you don't have stones. So this is a problem with biliary motility. And for that reason, we're not going to see anything on ultrasound. It's going to look completely normal. But because this is biliary-like pain, right upper quadrant pain comes and goes, maybe you have more pain with meals, we are suspecting that this is biliary, even if we have a normal right upper quadrant ultrasound. So yes, you can do CT, but that's also not going to tell you anything because the problem here with biliary dyskinesia, which is really biliary colic without a stone, the problem is motility. And so we need a test that is going to check motility. And that test happens to be the HIDA scan. Okay, and we give CCK because that's going to stimulate the gallbladder. But you should know it's a HIDA scan. So you've got a patient with biliary colic, but no stones present, and you might believe this is biliary colic at first, but if they don't have any stones, your next step is to do a HIDA scan to look for dysmotility. And what you'll see here is impaired gallbladder emptying. There's actually an ejection fraction. which we usually associate with the left ventricle. But here we are also measuring an ejection fraction. You don't need to know that. But what we do measure is how well the gallbladder is getting rid of the bile into the bile ducts. The treatment, again, here is an elective cholecystectomy. And this is what the HIDA scan looks like. Notice at the beginning, the gallbladder is full, and then it empties into the biliary tract, but notice there's still bile in the gallbladder. There's still tracer in the gallbladder, and so we just measure that and figure out what the ejection fraction is. Okay, here's another vignette. And you can pause these if you want. All right, the famous acute cholecystitis. You should know how to diagnose and treat this in your sleep. So here now we actually have a permanent, as it were, obstruction of the gallbladder. Again, typically at the neck or the cystic duct. The risk factors, fat female fertile in 40s. That's a very common mnemonic that you should know. Symptoms here, right upper quadrant ultrasound, right upper quadrant pain, fever, nausea, vomiting, and Murphy's sign. So Murphy's sign, what you do is you palpate and compress just under the right rib over the liver gallbladder area. Have the patient breathe in. If they stop breathing in all the way, then you have a positive Murphy's sign. So it's just an arrest in inspiration. You can also do it with your ultrasound device, and that's called a sonographic Murphy's sign, but it doesn't really matter. The classic triad for acute cholecystitis is right upper quadrant pain, fever, and leukocytosis. Jaundice is present in only about 10% of patients. Now, how would you get jaundice with cholecystitis? So what can happen, I'm going to draw here. Here's your gallbladder and the neck and the cystic duct. And this cystic duct comes in here. And what you have here is the hepatic duct, like that. So normally we would see jaundice if you have a blockage of the hepatic or the common bile duct. So here's your common bile duct here. Here's your hepatic duct here. So typically, if we have a stone in the cystic duct causing cholecystitis, we would not expect to see jaundice because jaundice needs to block the either the hepatic duct or the common bile duct. Well, what can happen is if you get a stone that's big enough, it can actually start to compress on the hepatic duct, and that would lead to jaundice. And we call this Murici syndrome. And that's why I said that proximity to the hepatic duct is important. The diagnosis here, right upper quadrant ultrasound. Again, CMP can show variable liver function tests. If there's Murici syndrome present, then you would see deranged liver function tests. CBC, of course, will show high white count. And the differential, remember, we need to make sure that we are ruling these other things out, which is typically pretty easy to do with right upper quadrant ultrasound. So again here, looking at that anatomy, if you have that compression right here, you would get jaundice. So again, here's a normal gallbladder. And then what you can see here, we don't see a stone. We see some biliary sludge here. But what you see here is pericholecystic fluid. And then we also see a thickened gallbladder wall. Okay, so here's sludge. And there's a stone right there. Okay, so our treatment here is going to be cholecystectomy. There is some disagreement, but it's kind of resolved now that we're going to do a cholecystectomy during the patient's visit once we get them stabilized while they're in the hospital. It used to be, we used to try NPO, antibiotics, the whole bowel arrest thing, and then see if they get better. And then if they do get better, do elective cholecystectomy at a time of their choosing. But what we find is that we need to do this within weeks. It's associated with better outcomes. And ideally, you just get the patient stable and do it while they're in the hospital so they don't have to come back. Now, it is important to bear in mind with acute cholecystitis, this is an infection, so we do broad spectrum antibiotics. You can go with an extended spectrum penicillin. That would be something like piperacillin tazobactam, for instance, or you can go with a carbapenem. Both of these provide really good coverage of gram-negatives and anaerobes, so this would be something like Mirum. Okay. All right, here's another vignette. You can pause if you want. So this is an interesting one. If you look at this, this looks like cholecystitis. But then when we do our right upper quadrant ultrasound, what we find is no stones. So what happens when we have cholecystitis but no stones? What we have is a calculus cholecystitis. Now, the presentation, diagnosis, and management of acalculous cholecystitis is virtually the same. The only difference is that we have no stones. But pretty much everything else is the same. What is important for you to know with acalculous cholecystitis is that it's associated with some other things. And the big one is severe illness. So often these patients will already be hospitalized. I put here some really important things: sepsis, burns, trauma, dehydration, mechanical ventilation. Another one could be total parenteral nutrition. Why? Because the gallbladder doesn't need to work. And so the gallbladder is under some amount of stasis. So with biliary stasis, you've got more opportunity for stones to form, but you also have disorder in the movement of bile, and that can cause a cholecystitis. So just being on TPN, it raises your risk both of calculus acute cholecystitis and then of acalculous cholecystitis for two different reasons. Number one is that the stasis can cause stones to form, and number two, stasis can lead to an infection itself. Very similar to why we see UTIs in older men with BPH who have urinary retention. The management here is very similar, basically the same to calculus acute cholecystitis, and cholecystectomy is the ideal therapy. So again, here you see pretty much the same thing, but no stones. All right, another vignette. All right, so what we see here is a picture that looks very similar to cholecystitis, except now we have jaundice. So this is choledocholithiasis, and this is an obstruction of the biliary tract, but further down, rather than at the gallbladder neck or the cystic duct here, now we're at the common bile duct. This is going to cause all your symptoms of acute cholecystitis, but also an obstructive jaundice. Now, again, this can masquerade as something quite a bit less common, but we already talked about it, which would be acute cholecystitis with Moritz syndrome. But if you see right upper quadrant pain and jaundice in a patient who's had stones, you should definitely be thinking of choledocholithiasis. So again, best initial test is right upper quadrant ultrasound, but make sure that you're looking at the common bile duct. What you would see is a stone in the common bile duct and then dilatation proximal to the stone. On your CMP, you should see elevated ALK phos and GGT because we're dealing with a pathology of the bile ducts here. And the treatment here is a little bit different. So removing the gallbladder is not going to be enough because the stone's in the common bile duct. So instead, we have to go in and retrieve the stone. And ERCP will do that. So ERCP is actually diagnostic too, because we'll be able to see that the stone is in fact in the common bile duct, but then we can go in and we can remove the stone or place a stent, and that is going to help drain. So we need to do that. So it's going to be ERCP with sphincterotomy and or stone extraction. We got to get that stone out, and we cannot do that with a cholecystectomy alone, but these patients will go on to get elective cholecystectomy because remember, the ultimate origin of that stone is in fact the gallbladder. So here you can see it in the common bile duct. You're probably not going to get shown this on your exam because it's really hard to know exactly where you're at just by looking at this. All right, here's another vignette. All right, why did I highlight these things? We're going to see. So this is acute ascending cholangitis. So as, let me see if how I can put this. As biliary colic is to acute cholecystitis, choledocholithiasis is to acute ascending cholangitis. So this is an infection of the biliary tree rather than just the gallbladder. And it's usually due to choledocholithiasis, but there are other possible causes, including stenosis and primary sclerosing cholangitis. This is an emergency here, and you're going to know based on how the patient presents. So not only are you going to have right upper quadrant pain and fever, but you're also going to have jaundice. Now, they'll probably be really clear on your exam because it's hard to know this from Maritzi syndrome unless you can look at the ultrasound. So what they'll probably tell you are a couple other things, and that is that the patient has hypotension and altered mental status, and that is Reynolds pentad. So it's Charcot's triad plus two other things, and this is very, very specific for acute ascending cholangitis. Now, the best initial step is going to be to stabilize them. Obviously, if they're hypotensive, you need to give fluids and make sure you're doing pain control and antiemetics. Your lab workup needs to include blood cultures here, and that goes for any time a patient's coming in febrile and they've got a high white count and they look sick. You need to make sure you're getting blood cultures. Start your antibiotics right away, same antibiotics that you'd use for cholecystitis, and then look for that right upper quadrant ultrasound. Treatment here is very similar to choledocholithiasis. It's going to be ERCP with biliary drainage, retrieve the stone if there is one. This is, again, both diagnostic and therapeutic. These are some of the gallbladder-related complications. I'm not going to go into each of these, but you should be aware that this can get worse. The gallbladder can become infected itself. You can get this emphysematous or gangrenous cholecystitis, which kind of exist on the same continuum. But they are both complications. Emphysematous cholecystitis, where you have an infection in the gallbladder. That infection then gets into the wall, causing air pockets to form. Obviously, these are caused by anaerobic organisms. Gangrenous cholecystitis is when the cystic artery is affected, leading to ischemic necrosis of the gallbladder. And then perforation of the gallbladder can be a further complication. So this is my approach to right upper quadrant pain without jaundice. So get that right upper quadrant sono after you get all your labs. If it's unremarkable, your next step is a HIDA scan looking for biliary dyskinesia. Remember, we're looking at the ejection. If there's stones only in the gallbladder but not in the gallbladder neck or in the cystic duct, then you are probably dealing with biliary colic, especially if they're afebrile. However, if they do have a fever and an elevated white count, you may be dealing with acalculous cholecystitis. Look for risk factors like being hospitalized or having some other disease process. If there are stones in the gallbladder neck or cystic duct, you know what you're dealing with. This is acute calculous cholecystitis. The treatment for acalculous and calculous are virtually the same. If there's a stone in the common bile duct, these patients are typically afebrile, don't show signs of infection, just the right upper quadrant pain. That's choledocholithiasis, and we do ERCP and stone extraction. Now, if you do have right upper quadrant pain with jaundice, you do all the same labs, but then make sure you are stabilizing them if they're febrile or hypotensive or have altered mental status. So that should always come first. In that case, you do resuscitation and IV antibiotics. You're likely, you've got Charcot's triad or ideally Reynolds pentad if you're on an exam question. So it's ascending cholangitis. Our next step is to do ERCP and drainage. If you see a CBD stone, then you need to do a cholecystectomy at some point in the future. If you see a stricture, you need to ascertain the underlying cause, and there are a number of them, which I included down here. Now, if you have a patient who's stable, get the right upper quadrant ultrasound. If it's unremarkable, but you still suspect a biliary etiology, get CT or MRCP. If you do see a stone in the common bile duct, then you're dealing with choledocholithiasis. You go in and extract the stone with ERCP and then do cholecystectomy. And if there's a stone in the cystic duct, then what you have here is acute cholecystitis with Merizzi syndrome, where you have that impingement upon the common hepatic duct. And then here is a recap of everything we talked about. Very, very, very high yield stuff for your exam.